Hello, this is a didactic on buprenorphine, a first line consideration for pain management, which was adapted from a 3 hour intensive on this subject. I don't have any financial disclosures. I can tell you that I've been using buprenorphine in low dose FDA approved formulations since 2010 and in the higher dose formulations used for the treatment of pain or opioid use disorder since 2018. In this didactic, I'm going to discuss the unique pharmacologic properties of buprenorphine, the various formulations and their indications for use to treat pain, and talk about which patients may benefit from the use of buprenorphine and how we can treat people who have pain and substance or opioid use disorder by incorporating harm reduction strategies into our practices and implement strategies to help you better manage buprenorphine therapeutic regimens across different care settings. So, what is the difference? What is the difference with buprenorphine? So, buprenorphine has unique properties. It's considered a partial agonist with very high binding affinity for the mu opioid receptor, but it's an antagonist with a high binding affinity for the kappa and delta receptors, and an agonist with low binding affinity for the opioid receptor like 1 receptor. So the partial agonism at the opioid receptor does not mean that it only provides partial analgesia, but the analgesia can be equivalent to that of a full mu receptor agonist. But unlike full mu opioid receptor agonists, it may have the unique role in terms of that you may have different challenges or less challenges with euphoria, addiction, and respiratory depression. That's because most of its mechanism of action takes place within the spinal cord versus the nucleus accumbens. One of the things when we think about kappa antagonism is that we may see reduced depression, dysphoria, or anxiety, and may limit the potential for addiction and tolerance. It has been studied off-label for treatment-resistant depression, so we may find that some patients may have an actual benefit in terms of mood, but again, this is off-label. Buprenorphine has very poor GI bioavailability. That's why it's administered either sublingually, buccally, transdermally, or intravenously. It can be used for those that are in renal failure and mild to moderate hepatic failure. While it has some drug-drug interactions due to the CYP450, 3A4, 2D6, less clinically relevant than when we see, say, for example, with methadone. While it may cause QTc prolongation, it's not been associated with development of torsade de pointe, and in fact, we're not really routinely monitoring EKGs like we do when we initiate and treat people with methadone. This is a nice visual of its view as a partial agonist. So when you see about the partial agonist or the full agonist heroin or say fentanyl, the percent of mu receptor intrinsic activity increases, with the dose. Whereas you see with the partial agonist that even with dose increases, you do not see that full mu receptor agonist increase, unlike the antagonist naloxone with none. So it's got a strong affinity for the mu receptor, which means that once buprenorphine is taken, it really latches on to that mu receptor. And that's where one of the unique challenges come when patients are already taking other opioids and you initiate buprenorphine, especially high-dose buprenorphine. It can displace the other opioids from the mu opioid receptor, thus someone could experience withdrawal. Now, increased affinity, meaning the way it attaches to the mu opioid receptors, does not equal activation. So that's where we see that it may attach, but it may not activate. Theoretically, it blocks other opioids from binding to the receptor, but in practice, we can see at higher doses, other opioids still can be effective because even at high doses of buprenorphine, which are used for opioid use disorder, where supposedly up to 90 something percent of the mu opioid receptors are activated or it's attached to, there's still other receptors that opioids can attach to. And in this age where we have this super potent high dose illicit fentanyl, it could potentially override the buprenorphine that's attached to the receptor. And there's a controversy whether there's an analgesic ceiling dose effect at higher doses. And I think it's just because it has not been studied. Now, buprenorphine can take up to 72 hours to disassociate from the mu opioid receptor. Thus, if you have someone who was on buprenorphine, that stopped it, and you were treating with mu opioid agonists such as your fentanyl, your morphine, your hydromorphone, it may take 72 hours before you get that full effect. So you would have to be careful because you may be treating with higher doses in the inpatient acute setting and find that after 3 days, that person may experience increased risk for respiratory depression once the buprenorphine displaces itself from the mu opioid receptor. We'll talk a little bit about buprenorphine formulations and describe the use of various formulations. What are the indications and the contraindications for use? This is a busy table. You please excuse, there is no DEA X waiver required. I'm sorry, the slide is not updated, but you have 3 formulations that are FDA approved for pain. And this is your Butrans, which is a low-dose transdermal patch, your Belbuca, which is a transmucosal film, and then your intravenous. We'll talk a little bit more about them in the coming slides. And then your high-dose buprenorphine, which is used to treat opioid use disorder, but also used off-label to treat pain. And this comes with your buprenorphine naloxone, or brand name Subsolve. Your buprenorphine without the naloxone, that's typically used in pregnancy or for those with liver failure, or your Sublocade, which is a monthly injection. Now, people ask, well, how do I rotate someone to buprenorphine? What's the equal analgesia? And the problem is it's not straightforward. And this may be because it's working on multiple receptors. Remember, you have your kappa antagonism, your delta antagonism, your ORL1 agonism. So the reported analgesic dose ranges is from 1 milligram of buprenorphine equals 10 milligrams of morphine to 1 milligram of buprenorphine equals 100 milligrams of morphine. Your buprenorphine patch, 5 micrograms per the package record says, is probably 10 to 12 milligrams of oral morphine daily, which would be a 1 milligram of buprenorphine equals 83 milligrams of morphine conversion. Your buccal buprenorphine, which is FDA approved for pain, 150 micrograms every 12-hour doses. The plasma levels are similar to a 10 microgram transdermal patch, and 300 microgram every 12 hours is equivalent to a 20 microgram patch. As a note, the leading pharmacist expert, Mary Lynn McPherson, does not include buprenorphine analgesia in her book on demystifying opioid conversions. A few key points about the different formulations. Remember, the buprenorphine patch and the buccal low-dose FDA approved for pain. These are for people that require around-the-clock analgesia. The key point here is that someone can be opioid naive. I can start this on a 94-year-old who has never taken any opioids. The buprenorphine sublingual or buccal high dose that's FDA approved for opioid use disorder is never used in someone who is opioid naive. Now remember, the naloxone that's in these buprenorphine products is only there so that if the product was tampered with and injected, it would inactivate the buprenorphine. We tend to use that product, the buprenorphine naloxone, because it was felt that this single agent buprenorphine only products had more street value because they could be abused more easily. I can tell you in my own personal practice, I'm using the mono product more and more because it may be more cost effective when patients do not have good insurance. You want to use the naloxone formulation in those with pregnancy because it has not been studied, or in those with hepatic failure. And again, we do use this off label for pain, and we'll talk about this later. What are the benefits of the buprenorphine patch or buccal buprenorphine? It's a Schedule 3 opioid. So that means for my patient that I have right now that's in an assisted living who has terrible low back pain and requires some type of analgesic more than acetaminophen or nonsteroidal, this is a perfect medication that I can have a buprenorphine patch that's changed once a week, and I can put renewals on it. You may have less risk for constipation. It may cause less dysphoria or euphoria. And again, there's this ceiling effect for respiratory depression. We'd want to use this if we had pain that's not relieved with non-opioid options. Again, we can use the patch in someone who's not had any opioids in their system. It may be perfect for that person that really needs around-the-clock analgesia, but say they're only taking 2 or 3 hydrocodone acetaminophen a day. They're really not a candidate for something like your extended release oxycodone, extended release morphine, or fentanyl patch. This is the perfect candidate for this. And again, I've already outlined the ease of prescribing because it's a Schedule 3 opioid. It's good if someone requires less than 80 milligrams of morphine equivalent. I love to use it for those that live in assisted living or nursing facilities, or if I have someone that lives alone. I think of someone I saw yesterday in their 90s, lives alone, but she has a caregiver come in once a week. I love it for people that have concerns about pill burden or may have difficulty swallowing. If we're thinking about the buccal buprenorphine that's FDA approved for pain, again, you can use the lowest dose, 75 micrograms every 12 hours, someone who is opioid naive. This would be for someone that may have skin irritations from the patch, or they can't take extended release opioids by mouth. Again, it may be helpful if someone requires more than 80 milligrams of morphine equivalent, so therefore the highest dose patch that we have available in the United States would not be effective, but they need less than 160 milligrams of morphine equivalent daily. So this buccal buprenorphine for pain is not the same as the buccal buprenorphine for opioid use disorder. The formulations are 75 to 900 micrograms every 12 hours. And again, it's generally effective if the morphine equivalent daily dose is less than 160 milligrams. When do we then move to using the FDA approved formulations for opioid use disorder? Well, if I'm thinking about using it for pain management, it's when the maximal dose of buccal buprenorphine is reached and I have no adequate relief, or I have someone who has a history of opioid misuse, or someone who already has opioid use disorder and disease-related pain. I sometimes use it in patients who are survivors of cancer when they have no further evidence of disease, but yet are still on high-dose opioids as a way to potentially try to wean them off of opioids. I'm going to talk very briefly about general considerations to prescribing buprenorphine, or for that matter, any opioids. If you're not already doing it when you prescribe opioids, I would highly recommend that you consider universal precautions for opioid prescribing. And that's with any patient that you're prescribing opioids. Now, some people might say, well, why would I want to use it in someone who's on hospice? And maybe you won't if that person has a life expectancy of days to short weeks. But I have patients that have been on hospice for months, and that person may benefit from using universal precautions for opioid prescribing, which really means that we're going to do a comprehensive pain assessment. We're going to do an opioid risk assessment using standardized tools that can be utilized. Talking about the treatment plan, looking at reassessment, using urine drug screening, really to assess for, is the person taking the medication that we prescribe? Because we also have challenges where there are times that patients may not be taking what's prescribed, but other people in their immediate circle may be. Using informed consent or treatment agreement. This is not a contract. This is really just an agreement that we have with our patients as to how they're going to manage their meds. And really looking at the prescription drug monitoring program to see, for consistency of prescribing, making sure there's not multiple prescribers, and then coordinating with our other colleagues. We should prescribe naloxone for all patients who are not at end of life with imminent death. Those that are diagnosed with a substance use or opioid use disorder that are either actively using or that they're on medications for opioid use disorder, and even those that are in remission not on medications for opioid use disorder because they may be at risk for recurrence of use, and we want to make sure we have safety precautions in the home. Anyone who's on high-dose opioids, which the Centers for Disease Control say is someone who's on more than 50 milligrams of morphine equivalent daily. Those at risk for overdose, frail, organ dysfunction, or who have safety risks at home. And I think about anyone who has children, young adults, teenagers in the home. So again, we're going to go on to choosing the most appropriate buprenorphine formulation. And we're going to use a case. So T is a 45-year-old woman with non-small cell lung cancer with reports of thoracic pain secondary to the lung mass. She's currently being treated with chemoimmunotherapy. She's taking high-dose acetaminophen and nonsteroidals, which are not effective for pain. She's drinking 6 hard linker drinks daily to manage the pain. She has a previous use of high-dose opioids for low back pain with subsequent misuse and justice involvement. Terribly afraid of taking opioids because of her previous history. She's divorced and lives with a daughter and granddaughter. She's disabled. She has strong faith support, and she has Part D medication coverage. So we're going to decide to start buprenorphine patch due to the fear of opioid use. Now, what dose would you start with the buprenorphine patch? And in the slide deck that goes along with this, you will see supplemental slides on the different formulations. And how would you dose the patch? So you might want to put this on pause for a moment and then continue once you've made the decision, because I'm going to give you the answer in the next slide. We would start her on the 5 microgram patch because she's taking less than 30 of morphine equivalent daily dose. We can't count the alcohol. She'll probably need more, but that's where we would start. And the patch is dosed once every 7 days. Now, there is a caveat that like fentanyl, like oxycodone, like morphine, some people experience end-of-dose failure. So there are some patients that I find that I need to change the dosing frequency to every 5 days. So would you prescribe opioids for her for breakthrough pain? And when would you titrate the patch? So take a moment, put this on pause, and formulate your answer. And then click the start button when you're ready to see the answer. You can prescribe opioids for breakthrough pain. You can do this when they're on the low-dose buprenorphine patch, but you may not want to do so in this case because remember, you're dealing with a patient who has a prior history of substance use disorder with justice involvement, meaning incarceration. So, and very, very afraid to use opioids, so we want to be really safe with this patient when we're treating. You can titrate the patch after 72 hours when it reaches steady state. Do I expect you to remember this all? No. But this is when you can use the product insert, go to the website, and easily get the answers. What are some of the components of patient education? Like any opioid, there are opioid side effects, although you have much less risk for respiratory induced depression unless the person is also taking benzodiazepines, drinking alcohol, or on a lot of other CNS type respiratory depression medications. Patch adherence, you want to make sure that the patch is in a spot not full of hair, that it will adhere. I like to use the upper arms, not to put any application of heat over the patch, because remember that could cause the medication to be absorbed much more rapidly, and remove if there's high fever. So the buprenorphine patch is titrated to 7.5 micrograms an hour, then to 10, and then the pain control as achieved at 15 mics an hour. No breakthrough opioids are prescribed because of a past history of substance misuse. However, she develops a significant rash from the patch. You decide to rotate to buccal buprenorphine, FDA approved for pain. Again, look at the supplement. What dose do you start? How do you dose it? And what is the maximum dose? So go ahead and put your recording on pause and come to the answers, and then go forward. In this case, we would start at 150 microgram per hour because she's taking more than 10 microgram per hour. If she was on the 20, we could probably start her at 300 micrograms an hour. It's dosed every 12 hours transmucosally. And for this FDA formulation of buprenorphine, the maximum dose is 900 micrograms every 12 hours. So how do you titrate the dose, and what would be a contraindication for use? Again, put your slide deck on pause, and when you're ready, go forward. So you would titrate it no sooner than every 4 days, and people ask the rationale, and I say I'm really looking at the product insert, which is how I go forward with the titration. If someone had severe mucositis with a lot of open sores in the mouth, that to me would be a contraindication for use. So I'm going to give you a case example now of one of the patients that I care for. She's a 55-year-old woman with triple negative breast cancer. She's status per surgery, radiation, and chemotherapy, and has no evidence of recurrent disease. However, she has significant pain secondary to lymphedema to the left arm and chest wall. She had trials of multiple agents, including gabapentin, pregabalin, topiramate, nortriptyline, morphine, and oxycodone, with adverse effects. She utilizes non-pharmacologic strategies using compression and massage. But however, when she came for her first visit, she had suicidal ideation secondary to unrelieved pain and poor quality of life. She did get efficacy with a compounded cream of ketamine, lidocaine, gabapentin, ketoprophene, as well as ketamine troches. However, it wasn't covered by insurance and was costing $450 a month. She was started on buprenorphine 5 microgram an hour patch, which provided significant pain relief without side effects. And she was gradually titrated to 15 micrograms an hour every 7 days. She experienced end-of-dose failure at day 5, and we changed it to a every 5-day dosing. She was able to tolerate hydromorphone, 2 milligrams every 4 hours when pain was severe and when she ran out of her compounded cream. The patch was titrated well controlled at 15 micrograms an hour. However, she developed terrible vasomotor symptoms, so perspiring all the time, and the buprenorphine patch would not adhere. She was started on buccal buprenorphine and titrated to 300 mics an hour, 300 mics every 12 hours with efficacy. So this is an example of how starting someone who's opioid naive on a patch and transitioning onto buccal buprenorphine with very good pain control. And this is a couple years later. So let's talk about strategies in managing buprenorphine across settings. And when we think about buprenorphine for pain and substance misuse, I think it's important to look at the fact that we are now in wave 4 of opioid related overdose deaths. We saw wave 1 start in 1999, where we had a rise in prescription opioid overdose deaths, really because we had liberalized opioid prescribing for chronic pain. And then in 2010, we started to see a rise in heroin overdose deaths. And this coincided with a lot of concerns about opioid prescribing for chronic pain and a lot of risk evaluation mitigation strategies, a lot of provider education, a lot of pullback from providers on prescribing opioids for chronic pain. And so then the burden shifted to heroin. In 2013, that early, we started seeing a rise in synthetic opioid overdose deaths. And when we're talking about synthetic opioid, we're really thinking about your synthetic fentanyl. When people say they're using heroin, at least where I live in Northeast, you're not seeing any heroin anymore. It's all synthetic fentanyl, which is being also placed into pressed pills. And then what we started to see in 2015 till now, which we're not even talking as much, is that we're seeing a lot more of psychostimulants. And that is where we're really starting to see the rise. And as you can see on this national drug-involved overdose deaths from 1999 to 2020, really where like you can see that the cross between regular opioids and heroin and synthetic opioids started changing back in 2014, and it's off the chart now compared to prescribed opioids or heroin. And you can see now psychostimulants is now number 2, and we're seeing a lot of overdose deaths with combinations of opioids and psychostimulants. When we're thinking about treating pain, it's a balancing act. We want to make sure that we, pick a safer opioid, one that may be a risk mitigation. And this may be buprenorphine. We might be thinking about using only long-acting opioid monotherapy, and this could be something even as directive as RNs observed applying fentanyl patch. We might do short refills. We might have frequent visits. We might minimize benzodiazepine use. We want to engage in conversations about safer use. We want to do overdose education, make sure that there's naloxone for overdose prevention in every household. And we want to acknowledge the person's history and give positive regard. For ourselves, we need to look at our own stigma, our own bias, and realize that we have our fears, but then patients also have their fears. We have to remember that the risks for substance use disorder are multifactorial, that biology and genetics may account for up to 50 or more than 50%. But also there's the environment, chaotic home, abuse, parents' attitudes, peer influences, community attitudes, the route of administration, early use, all of this plays in. And so we need to recognize that substance use disorder is multifactorial in order to provide that best care possible. So does your patient have a substance misuse or substance use disorder? If your opioid risk screening indicates high risk, or you have concerns based on your history or clinical interview, you can use assessment tools that are either available in your institution or go to this National Institute of Drug Abuse screening tools resource that gives you a lot of tools. But remember, some of your patients with substance misuse may not fit the diagnostic manual criteria for a substance use disorder. You may have patients that are taking substances in larger amounts than planned. That would be one point. You may see patients that end up with social interpersonal problems related to use. That might be a second point. You can't use tolerance and withdrawal because it's not applicable if they're already on opioids under supervision. So again, there may be people on the spectrum of at risk for developing a substance use disorder, but may not have an actual substance use disorder. And in the days when you're thinking about starting someone on buprenorphine, for example, or methadone for substance use disorder, you need it to be moderate to severe. And I look at it now that if I'm thinking about using buprenorphine for pain, if there's someone that's mild that I'm worried may progress to a higher risk with use, I may want to use this as a risk mitigation strategy for safer use. Again, we want to utilize a harm reduction approach. So this is not a coercive approach. This is an approach that we want to use strategies that I'll talk about in later slides. We want to use multimodal analgesia, medications from different classes of medications to synergistically work to treat pain. Obviously, if you have access to mental health providers, you want to make sure that that person's mental health is being attended to. You want to advocate for safe management. And if that person is already on medications for opioid use disorder, you want to collaborate with that prescriber. If you take nothing else from this lecture, think about language. It matters. With all the talk now about diversity, equity, inclusion, and wanting to make sure that we provide that type of care, it matters the language we use. It matters the language that we chart. You put the word junkie or addict in a chart, that labels that person for life. That person is not an alcoholic. That's a person is someone who drinks alcohol. Again, we don't even use medication-assisted treatment because that's sounding like that it's just an adjunct. But these are medications for opioid use disorder. And I liken it to, we don't say diabetic-assisted treatment when you're using insulin. It's treatment for diabetes, the same thing. We don't want to say relapse. We want return to use. Recovering addict, person in long-term recovery. Now remember, some of your patients may say, hey, I'm an addict. And that's okay if they self-refer that way, but you have to think about in your own use of words, not to use that type of stigmatizing language. Utilize harm reduction strategies. So that's meaning that recognize there's a continuum of substance use disorder. From risky drinking, for example, to binge drinking, to daily drinking that's impairing function. And you want to accept that it's a continued drug use as a potential reality. You don't want to minimize the harm, but for example, when I started treating a patient last year who had stimulant use disorder, and I put him on buprenorphine to also treat his cancer-related pain, I said, I don't care if you go back to using your meth. I'm not going to abandon you. I'm going to still treat you. I would love for you not to use, but I'm not going to discontinue treatment. Now, if someone was selling all of their medicines to get the meth, that might be a different story. But I'm not going to minimize the reality of harm and accept that there's going to be possible recurrence of use. You want to listen to and empower patients. While we want to avoid coercion, it doesn't mean at the same time that we're going to say, well, we're going to give you whatever you want if we realize it may cause more harm than benefit. But we also have to acknowledge that there are biases and inequalities exist, and that is just the reality of our care. We want to avoid strategies that may cause harm. You don't want to just say, this person's going to die anyway, I'm just not even going to discuss it. And you don't want to say care with all or nothing. You may have to say, I'm not able to further treat you with your oxycodone, but I can offer you buprenorphine, which is a safer alternative. You want to recognize, again, that there have been inequalities and that someone, I have patients come back and say to me, well, yeah, you've got me on this buprenorphine for pain, but I'm treated like an addict when I go into the emergency room. And remember that this takes work. This takes modeling for our colleagues, modeling for those that we're teaching on the best way to take care of patients. And even though this is an older slide from 2019, realize the availability of medications for opioid use disorder inequities exist. It's really hard when you see that all those red areas are areas where there's not enough providers for people with opioid use disorder. We hope that that changes. And yet, yes, this is, back in 2017, this is published in 2019, but we still see this exist. For those know that xylazine, which is a veterinary tranquilizer known as a zombie drug, that 23% of fentanyl powder and 7% of pills contained xylazine in 2022. And we see increased deaths associated with this. It's an alpha 2 receptor agonist in the central and peripheral system, so it potentiates the opioid effects. This might be why people want to use it, but it can cause hypotension, hyperglycemia, and the biggest thing we're seeing are these horrible necrotic wounds. It's not reversible by naloxone, but it can cause increased somnolence. So you may be reversing someone with naloxone that you found down on the street or in your hospital room with what you felt was an opioid-induced respiratory depression. You may be bringing that respirations potentially back somewhat to normal, but maybe still over-sedated from the xylazine. And this can make initiation with buprenorphine or methadone more challenging because of the sedative effects. This is the same slide that we saw earlier about the buprenorphine formulations. Again, excuse the fact that it says X waiver. There's no X waiver required. And we'll talk about the higher dose. Now, there's different ways of initiating high-dose buprenorphine, and this was taken from a great article by Dr. Weimer et al. In 2023 about high-dose initiation, standard dose, and low-dose initiation. We're only going to be talking about traditional and low-dose initiation. When we're thinking about high-dose initiation, this is what we're seeing happening a lot of times in emergency rooms when people come in with a overdose secondary to high-dose fentanyl. And with high-dose fentanyl, it can take sometimes up to a week before someone goes into complete withdrawal, because if they've been injecting fentanyl daily or multiple times daily, that fentanyl is storing in the adipose tissue. And if you try to do your traditional initiation, you push that person in withdrawal. And so the theory behind high-dose initiation is you basically overwhelm the receptors with buprenorphine using 8 to 16 milligrams a dose to try to get them over that withdrawal. So if we're going to initiate buprenorphine in the traditional initiation, which is what I've used most often before the age of fentanyl, the patient has to be in opioid withdrawal. Now, if they're not on methadone and if they're not using street fentanyl, most of that happens within 24 hours. Again, I've talked about the complications with illicit fentanyl and xylazine. You want to screen for opioid withdrawal. And again, your institution may have its own scales. The clinical opioid withdrawal scale is one that's most often used. And these are some of the side effects, some of the effects of opioid withdrawal. We see tachycardia, sweating, restlessness, bone joint aches, runny nose, GI upset. And we want to treat that opioid withdrawal at the same time that we're going to treat with buprenorphine. So we may use some of our alpha 2 adrenergic agonists. This is your clonidine. This is basically to tamp down the noradrenergic effects from the locus coeruleus and decrease the terrible effects of the withdrawal. But we also may need to symptomatically treat the bone and joint pain with your nonsteroidals, treat with abdominal cramps, treat nausea, diarrhea, and restlessness. The true equal analgesia is not established, but basically you would start with 1 to 2 milligrams and titrate hourly to pain efficacy or cravings. You can see the SAMHSA guide, a sample initiation guide, but you would adjust that for pain management. If you're giving this for pain, you're going to give in split doses every 6 to 12 hours to manage pain. So much like you're thinking about with methadone. Methadone given once daily reduces cravings, but methadone used for analgesia must be dosed every 6 to 12 hours. You want to make sure when you're prescribing, if there's opioid use disorder, you put opioid dependence on the prescription. Some people have told me this is no longer accepted. You would need to put opioid use disorder. I have some people that I don't feel have an opioid use disorder, but they may have a substance misuse or dependence. And that's where I get into some of the logistics. If I put that I'm treating for pain for someone who does not have a true opioid use disorder, and I'm using this off-label for pain, I may run into some challenges with insurance, although I'm seeing that less and less now. We would hope that one day that the higher dose buprenorphine that's FDA approved for opioid use disorder would be also FDA approved for pain. There's no realistic reason why it should not be. I think this is part of the challenges we have with our own system in the United States in terms of stigma and bias towards the treatment of addiction. That's my own commentary. If we think about a traditional initiation, we're going to start 1 to 2 milligrams. I always start 1 milligram when the patient begins to be in withdrawal. If we give that 1 milligram and they start having more withdrawal symptoms, we wait and try later that day. If they tolerate it, we may repeat every 1 to 2 hours. On day 1, I usually only go up to 8 milligrams. On day 2, they take the total of day 1 in divided doses, and then I would continue to titrate up depending on if they still have craving or pain. You can titrate up to 24 milligrams daily, but generally it's not needed. Most of the time I can get pain relief with 16 milligrams, but I do have some people on 24 milligrams daily. It's not been studied in doses in greater than 24 milligrams for efficacy, but safety has been established at 32 milligrams, and I have a few people that are on 28 milligrams daily. Now, I alluded to the high dose initiation, and again, this is when we have someone potentially in the emergency room or comes in the hospital that needs quick stabilization. That person has to be in opioid withdrawal, but we may want to override that because they may be in that initial withdrawal from the fentanyl, but there's still a lot of fentanyl in their system. So we may need to override that and titrate up to 32 milligrams. And again, best done inpatient or in the emergency setting. What happens if a person is already on opioids? So the basic concept, this is low dose initiation, is to start buprenorphine, whether it's the patch, IV, or low dose transmucosal, and continue the current opioid. And over a period of days, you slowly increase the buprenorphine up to 8 to 16 milligram dailies in divided dose. And at the same time, you're decreasing that full mu agonist or abrupt discontinuation once the buprenorphine is full dose. There are multiple low dose initiation methods. There's not been randomized controlled trials at the time that I am recording this lecture. Most is based on case reports and case series. Use of the buprenorphine patch or buprenorphine IV to start. Use of low dose sublingual buprenorphine that's FDA approved for opioid use disorder. I can tell you in my own practice, I've only done it a couple times because most of the time when I have started, I've either titrated someone up through the patch and buccal buprenorphine to Suboxone or Subutex because they now have higher pain management needs, or if they had risks for or had opioid use disorder, some of the times it happened because this patient had misuse or opioid use disorder and put themselves into withdrawal, and we started. This is an example of low dose buprenorphine with opioid continuation, and it was adapted from our order set at Dartmouth Health. So, I may see that this person is already on opioids. If the patient is, having a high dose, you start with a very low dose, 0.5 milligrams daily, and still continue the opioid. And slowly you're going up to like a day 4, 2 milligrams twice daily, and still continue the opioids. Day 5, go to 4 milligrams twice daily and maybe decrease the full opioid by 50%. And day 6 through 10, continue going up and discontinuing. But again, I think it's something that I may have colleagues in other organizations that have a much more systematic approach. I personally don't, because I haven't done it that much. And I haven't done it on the inpatient setting because I only work in the outpatient setting. So if you have buprenorphine for pain, basically your pain management is off-label, but it has a dual purpose if someone has opioid use disorder or is at high risk for substance misuse. I do not use my full mu agonist opioids with buprenorphine, such as my hydromorphone, unless that person is hospitalized with acute pain or is in advanced disease or toward end of life. Remember, if you do use your full mu agonist opioids, such as your hydromorphone for breakthrough, you may need to use higher doses. And some, like hydromorphone or fentanyl, have a higher affinity for the mu opioid receptor, so may be much more effective to use for breakthrough than your oxycodone or your morphine. You want to make sure that you include home instructions on home initiation. This is the only way that I've done it in my outpatient setting, is home initiation. In previous years, they would have patients come in the office and do observed initiation. Perhaps that's still happening, but more and more we're seeing that it's just as safe for people to be able to do it at home. I can tell you from many of the patients that I initiated on buprenorphine for opioid use disorder and pain, these patients had already tried buprenorphine that they had obtained illicitly anyway and used it. You want to make sure that the patient knows to dissolve in the buccal mucosa or sublingually and not swallow, because if you swallow it, you get no effect. There's also was an FDA warning that came out about that buprenorphine can cause dental problems. I have only seen it potentially once in a patient, so you want to make sure that people know to rinse their mouth well and not brushing their teeth for an hour after administration. So the waiver and education is no longer required. However, as of the end of 2022, due to the Medication Access Training Expansion Act, it requires that all of us that are getting our DEA renewed actually have 8 hours of training. So there's a lot of the requirements are there under our SAMHSA. There's free mentorship. I love the provider's clinical support system. Great mentorship. They probably have a free webinar once or twice a week. Great webinars that are archived. And obviously, if you're going to start this in your practice, I started it in our practice in 2017 or 18 when I first was able to get waivered. And it's like you don't start with the most difficult patients, and you find someone to collaborate with. I didn't have many people to collaborate with in terms of learning how to use it for pain within the institution I work with, but external to the institution, I used a lot of colleagues. And there are more and more people in palliative medicine that are also dual trained in addiction, so you can find resources to help. Let's talk about a case of a 50-year-old woman who she had metastatic neuroendocrine pancreatic cancer, had multiple interventions, including a Whipple, and who was on oral agents for treatment. Anxiety, depression, attention deficit hyperactivity disorder, didn't have any history of substance use, but worked in a bar. Had significant abdominal pain with escalation of opioids to oxycodone extended release 80 milligrams every 8 hours and oxycodone 20 milligrams every 4 hours. She continued to request escalations of opioids. She was running out of medications early. She had urine drug screens that were positive for cocaine, although she denied use. And then methadone, she said she borrowed from a friend. Functional status was declining, spending most days in bed. No change in disease status, emotional all the time. I discussed rotation to buprenorphine. Initially, she refused. She said that I really was the one that made her an addict and left our office. And after 2 weeks and severe withdrawal, she requests the start of buprenorphine. So she's already in withdrawal, and we're going to, how would we initiate buprenorphine? And how would you titrate the dose? So go ahead and put your slide deck on pause. And when you're ready, we'll give the answer. So remember, she's already in withdrawal, or supposedly, she says she's in withdrawal. So we would start at 1 to 2 milligrams, and we can repeat this every 2 hours for a maximum of 8 milligrams on day 1. And then how would you titrate? You can take the total of day 1 and add 2 milligrams every 2 hours until decreased craving. Generally, like I said, it's 8 milligrams in day 1, 16 milligrams in day 2, if you're using for opioid use disorder. What are the key things we want to educate the patient about? Again, put on pause, think about what you want to do. You want to make sure that the person knows not to swallow it. Not going to help if you swallow it. Of course it's not going to work. I had a patient went to the ER and she says, well, they had me swallow it and it didn't do anything for pain. Of course it's not going to do anything for pain because you're swallowing it. Don't brush your teeth 1 hour after administration. So in this case, the buprenorphine was started and titrated to 16 milligrams over a period of 1 week. When the disease progressed, it was increased to 8 milligrams, 2 milligrams. Remember, 8 milligrams is the buprenorphine, 2 milligrams is the naloxone dose. So when you see that 8 and 2 or 16-4, the smaller number is your naloxone dose. Again, it's only there so that if the patient tampers with the film or the tablet to inject it, then the naloxone will inactivate the buprenorphine. Her pain is well controlled, function and mood has improved, returned to work full time, never realized she had an addiction problem until the oxycodone. And we're talking about someone now who is 5 years out with some progression of disease, still doing really well. What do we do though when we need to manage acute pain for the person who's on buprenorphine for pain and opioid use disorder? Again, this is when we're thinking about someone who is on high dose opioids. You want to make sure, again, that you screen for opioid withdrawal because we don't know if that person's potentially taking other opioids. We want to make sure that we treat withdrawal symptoms, and this is maybe someone who comes in with active use. Again, we've talked about before, treating the nausea, vomiting, diarrhea, bone, joint pain. Recognize there could be protracted withdrawal if they're using illicit fentanyl. And then again, if we're going to do withdrawal treatment, say this person's not on any opioids or medications for opioid use disorder, we can treat with methadone or buprenorphine. Treat with clonidine to help decrease the noradrenergic effect of the withdrawal, and again, the symptomatic treatment. I think we need to remember to screen for stimulant use. This is going to be a problem that's emerging. We're not paying enough attention to it. Is this person having hypertension, tachycardia, hyperthermia, agitation, seizures, confusion? Thinking about the withdrawal in terms of mental exhaustion, intensive depression, insomnia. There's no treatment strategies, no specific antidotes. Long term, besides motivational interviewing, cognitive behavioral therapy, contingency management, do we treat this person with stimulants? Again, that would be off-label. We need to remember when a patient comes in the hospital to screen for alcohol withdrawal. Alcohol is the most abused substance, far more than all the other substances combined. We just might not place it in the same basket because it's legal, but it is the most abused substance. And we want to screen for alcohol withdrawal symptoms, and obviously you want to make sure that if there's any risk for withdrawal, that you have benzodiazepines on board. Cannabis withdrawal, really? Is there cannabis withdrawal symptoms? Yeah, there sure is. There's anxiety, irritability, disturbed sleep, mood. There's no strong evidence for withdrawal treatment. Cannabis agonists, we're thinking about our dronabinol. Some hospitals systems allow people to bring their cannabis from home. Many do not. Again, it's not life-threatening, but you have patients that may have had really good appetite control or insomnia control with cannabis products, and they may need to recognize that they may have more problems with appetite or insomnia or anxiety in the hospital setting without cannabis. But how do we think about manage acute pain? Obviously, you want to do your medical history. If they're on medications for opioid use disorder, verify medications. If by chance they're on naltrexone, which is an opioid antagonist for either alcohol use disorder or opioid use disorder, and they're having pain, you need to discontinue. But remember, there is the once monthly naltrexone injection for opioid or alcohol use disorder. And if they've had that, it may take an awful lot of opioids to try to override it. And this is when you need to think about your regional analgesia and your multimodal analgesia. You should continue the methadone or buprenorphine. Although there is no clinical guidelines saying we should do it, there have been multiple experts that say we should not stop the buprenorphine. We used to think we've got to stop the buprenorphine because of the partial agonist and we won't be able to treat the pain. Absolutely do not, because the risk is if you stop the buprenorphine and that patient is discharged from the hospital before we can put them in withdrawal and put them back on the buprenorphine, the risk for recurrence of use and morbidity and mortality is increased. You may, if you actually continue the medications for opioid use disorder and treat over it with multimodal analgesia as needed, hydromorphone or fentanyl, you may decrease the overall perioperative use. This was recently highlighted in some publications. With the buprenorphine, you don't need to wean off opioids prior to restarting. You have that buprenorphine as a base, and you may decrease the risk for overdose after hospital. The patient that I told you about in the last scenario came in for an extensive resection, had a tumor that was attached to her kidney, had a pretty long transverse abdominal incision, was on epidural analgesia for a couple days. She was discharged day 4 stayed on her buprenorphine, but a little bit higher dose, 32 milligrams daily, with a little bit of hydromorphone for breakthrough pain. If the medications for opioid use disorder are discontinued during an acute care event, you've got to activate a safety plan. Restart the methadone or the buprenorphine prior to discharge. If that person had been on naltrexone and you can't restart it, you really need to provide education and counseling, because absolute increased risk for overdose, and naloxone for overdose prevention should be in that patient's hands at discharge. I can't emphasize this enough. I saw 2 events in the past years when this was not done, and the patient got discharged, was supposed to restart in a couple days, and died. And we don't need to see that happen. If someone's on buprenorphine and develops severe mucositis, if hospitalized, you could use an intravenous patient-controlled analgesia. If pain is severe, and resume buprenorphine once the mucositis clears. At home, you may need to rotate to another opioid, but it would depend on if you're using buprenorphine for pain or opioid use disorder or both. If you're just using it for opioid use disorder, you can't treat people with methadone for opioid use disorder unless they're enrolled in a federal outpatient treatment program. Unless the rules change by the time you're listening to this, I know there's some push to try to get wider access to methadone treatment for opioid use disorder, because again, our treatment of addiction in this country has been mired with stigma and bias, and punitive practices. You could use once monthly injectable buprenorphine if available at your institution. So let's go back to a case, and you receive a call from the emergency room. Your patient has fallen and sustained a hip fracture, is in severe pain, now hospitalized, and will go for a surgical intervention. Currently taking buprenorphine 12 milligrams, 3 milligrams in divided doses for pain and opioid use disorder. How would you advise the hospital clinicians to manage the acute pain? And what measures would you want to be in place prior to discharge? Again, put the video on pause, think about it, and then advance when you're ready for the answer. Bottom line, you want to continue the buprenorphine and use multimodal analgesia. You can consider hydromorphone for breakthrough pain. If that buprenorphine is discontinued, restart. Advise risk of overdose due to loss of tolerance, especially had been using illicit substances, and ensure that naloxone is in the hand of the patient. I'm meaning that in the hand, not at the pharmacy where they go to then find out it has a copay they can't afford. What about the use of buprenorphine in hospice? So the formulations for pain or opioid use disorder can be prescribed by any clinician with a DEA. Cost is the limiting factor, and we need to weigh the risk for benefits. One of my colleagues, Pam Moore, that I presented with at a national conference, she's a pharmacist with Summa Health in Ohio, was showing me the different costs. And you can see that the methadone is so much less expensive than the buprenorphine tablets or the buprenorphine with naloxone or the Butrans patch. But again, we need to weigh the risk and benefits. And in fact, I think it's becoming more embraced by hospices because one of the leading pharmacias that put out their newsletter in August actually talked about the use of buprenorphine in hospice. So hopefully we'll see it become more widely embraced. But think about this. Your patient is admitted to hospice, pain's well controlled on buprenorphine naloxone, and there's no longer using illicit substances. She lives with a 18-year-old daughter who helps with care. The hospice medical director calls to request change from buprenorphine to a full mu agonist opioid due to the cost of the buprenorphine. What do we do with buprenorphine in hospice given the costs? Again, think for a moment, put your video on pause, and then advance it once you want the answer. I would assess the risks versus benefits for the continuation of buprenorphine. If the prognosis is weeks to months and an at-risk home situation, she has a teenage daughter in the home caring for her, advocate to keep the buprenorphine. Also, your patient may be really invested in their own sobriety and feel really proud of their own sobriety and want to continue. And we should honor our patients with that. We should honor our patients for that and not withdraw this type of care just because of cost. Now, your patient has been on hospice for 3 weeks and is getting weaker, no longer takes oral medications or remembers to keep the buprenorphine film in the buccal mucosa versus swallowing it, sleeping 18 of 24 hours a day and rarely eating. How would you manage her pain from this point till the end of life? Again, pause, think about it. You could rotate her to a full mu agonist opioid, such as your morphine solution. Recognize it could take up to 72 hours for buprenorphine to clear the system, so you may need to use a higher dose at first and then decrease the dose. So some final words. An article, not going to, say, hey, this is because I'm one of the authors, but it's really the 10 top tips for palliative care clinicians should know about buprenorphine, and some of the top 10 tips. It's an agonist, an opioid with unique pharmacology and fewer adverse side effects compared to full agonists. It can be a really effective analgesic and may be a preferred initial opioid in selected populations. I'm not saying buprenorphine for all, but I think in select populations, it could be a perfectly fine initial opioid. And in fact, in the Veterans Administration's 2022 guidelines for the treatment of chronic pain says if we're considering treating with opioids, buprenorphine should be our first choice. There's multiple formulations, and really it really depends if this is someone who's opioid naive and just needs a little bit of low dose opioid for pain versus the other end of the spectrum, someone who's been using illicit opioids or has high opioid needs and may need a higher dose opioid. It's highly effective treatment for opioid use disorder, and it really minimizes the burden of that patient having to go to an opioid treatment program daily for directly observed treatment. It's got much less risk for overdose. And I've had patients on buprenorphine that are continuing to use alcohol and benzodiazepines daily. While there is still some risk for opioid overdose secondary to respiratory induced depression, you're not going to see it to the same level if that person was on a mu agonist opioid. There are several methods to initiate, and it really depends on your clinical circumstances and what's available. There are no really good equal analgesic conversions. They're not reliable. We should be continuing it with there's acute pain or in the perioperative period. And we as healthcare providers should be able to dispel the misconceptions related to buprenorphine use, and really prescribing buprenorphine to treat opioid use disorders in people with serious illness is essential and should be part of our palliative care practice because it actually addresses suffering, not only secondary to pain, but the suffering related to addiction. And I say this because people don't start misusing opioids and say, well, all I want to be when I grow up is an addict. That is not true. That is not what happens. No one who basically has been using will tell you many are not getting any euphoric effect. They're usually chasing the withdrawal. Finally, I want you to consider buprenorphine as a first-line tool in your pain management strategies. Consider to treat pain and uncomplicated opioid use disorder, and think about this as a way for harm reduction, equitable approach to care. There are multiple references listed here, and in each one I've put a little bit of a blurb about what they're about, as you may find them helpful. What you will see in some of your supplemental slides are a little bit of things about the use of multimodal analgesia, a revised opioid risk tool if you're not using one. This is one that I find that is the most effective. And then there's an opioid managed workflow that one could consider using if you're thinking about opioids. So thank you for your time and attention. This is the end of this recording.